Welcome to the Trauma Informed Lens podcast. Each week, Matt, Curt, Jerry, and the occasional special guest explore how the trauma-informed paradigm challenges traditional beliefs and approaches concerning a wide variety of areas. This podcast addresses psychological trauma in an educational manner and is not designed to replace mental health treatment. If anything in this podcast makes you feel uncomfortable or anxious, please talk to a mental health professional.
Welcome, friends, to episode 60 for the Trauma Informed Lens podcast. I'm back here today with Curt and Jerry, and to continue our conversation on heart rate variability and trauma. So we have a really, again, we'll post the article we're talking about today, but one I'm really looking forward to because I think we can go deep on this one in several different directions. So I'm excited to be back with you both. And as always, we start out with our bright, shiny objects of the week. And I'll apologize to our listeners.
I'm frozen.
I might be a little high. I got back from a flight from LA pretty late last night. But my bright, shiny object of the week is the folks in Southern California and LA County. Every time I go down there, I feel like between the great weather and the great people, it's just like getting a big hug from folks. And, so even though I'm a little tired today, I'm feeling good. I had trainings with Mary that we had on the podcast from Young and Healthy, as well as El Monte School Districts and the Violence Intervention Program as well, which I know will give us some new listeners. So I want to say hi to everybody from LA. So Jerry, what are you thinking about this week?
Right now, I'm thinking about babies. I'm got babysitting duty today, but really thinking about parents, and really to be a good parent, the amount of attention and energy it takes to be present, attentive, and attuned, and that it's almost like putting something away in savings, because the investments you make, although it's really difficult to stay that present all the time, it really does pay off. And, my grandson is 6 months old, so his brain is developing rapidly. So it's really a pleasure to kind of spend some time with him to kind of see what he's kind of exploring and discovering, but also to really remember how difficult it is to be a parent.
Very cool. Curt, what about you?
I looked back on a few of our episodes, and one that was not too long ago was an episode about the role of staff supervision in a trauma-informed approach. And it reminded me of how important it is to have almost a value as a part of your department or your organization about somebody who's available to make sure that the staff who are working with all of the individuals that we support have somebody who can listen to them and be attuned to them. And it just reminded me of that. And I've had some great interactions with the people who work for me who remind me of that. And that of course means that I find out that I was misattuned. That's one of the joys of leadership, is finding out that you're misattuned. And the good part about that is that you don't have to be attuned all the time. You just have to recognize it and repair it when you are. And so that was a really good one. As I look back on that one, I was like, yeah, I should do that a little bit better. And I'm lucky to have good people who are working for and with me that will remind me of those things and also forgive me when I screw up.
Very cool. As Jerry says, I think it's I think Jerry taught me this, is when you have the break in the relationship, the healing part is the most therapeutic. So, well, Curt, I'm going to turn it over to you again today. I'm hoping we take a little bit of dive into the cortisol rabbit hole, but there's a lot in this article to unpack. So I'll let you sort of introduce it. I do want to throw out as well, I believe it was episode sort of our intro to this topic, which might be great for people new to the podcast to review as well, around heart rate variability. So I'll hand it off to you.
Go ahead, Curt.
And I'll let you pick what part of this article we explore first.
Matt, so you know you're breaking up just a little bit.
Okay.
So if we're not responsive, it's probably because it froze up, and we might need to kind of regroup a little bit, but you are breaking up a little bit.
I'll see if I can fix that on my end. Will you introduce it to everybody?
Sure. So this article, while it is focused in on the population of people with autism spectrum disorders, I think there are points to take away from here that are larger than being focused on autism spectrum. And one of the things that I kind of took away from this was some of the ideas about the physiology of anxiety, some of the differences between anxiety and stress, that they are separate things. And certainly the ideas of, Jerry, you alluded to this last time about that this whole system that we're talking about, the purpose of it is to maintain balance or keep us in a homeostatic state and return us to that when we get out of our kind of stable state. So there's some really great points, I think, about this. I'll kind of start in with a quick review, and if you're looking at the article, I think it's worth pointing out on maybe the second page of the article, which should be page 33. Right after the introduction, there's about a 3-paragraph description of the physiology of anxiety and stress. And I think if you're looking for something that can really encapsulate that and give you some words to say and some concepts to think about, I think those 3 paragraphs are really great. They're really well written, they're very concise, and they pack a lot in there, in that they talk about both the immediate response to stress, which is activation in the sympathetic branch of the autonomic nervous system. So they talk about that, and then they also talk about that there are kind of 2 components to the parasympathetic activation. And one is to activate to limit the duration of the sympathetic activation, and the other is to titrate how far it goes. And so that's part of the parasympathetic division. I think that they just write that really well, and it's one of those that I've kind of used since I read this probably, I forget how many years ago, but it actually wasn't published that long ago. It's a great kind of 3-paragraph description. Then you also get the side of it that starts to introduce the activation and the actions of the HPA axis, which gets us the release of cortisol and that cascade of response, which is more of a it's still an acute response to stress, but it's a little bit delayed after the sympathetic activation. So I love that section. I think it's a great 3-paragraph section. If you're looking for some words to use to describe this to others and understand it, is a great section. So from that, I want to skip into basically a description of what this study was and what the goals were. So it really kind of had 3 goals. One was to determine whether or not there is a difference between both the resting states across these 3 groups of subjects. One group being healthy controls, the second group being individuals with ASD, and the third being people with an autism spectrum disorder and co-occurring anxiety. So it really was to look at the differences between those 2, 1 at rest, and 2, the responsiveness to a psychosocial stressor. And they used this test called a psychosocial stress test. And I thought that their adaptation to this was pretty astute, in that the typical psychosocial stress test has been characterized by a baseline or a rest period, and then you prepare to give a speech, and you get a preparation period to prepare a short speech. And then you have to be able to remember a number for later, or trace an object for later and remember it for later under a timed situation, which is meant to increase some stress. And then you got to give this speech about yourself, and then you have to do an arithmetic task, and then you get to recover from it. And I thought one of the things that in the methodology section of this test that they did, that it was pretty interesting in how they adjusted the psychosocial stress test to people with autism spectrum disorder, who often have a heightened ability and a preference for arithmetic tasks, is they changed it. and said maybe arithmetic would not be a psychosocial stressor for this group, given the characteristics of this individual group. I thought that was interesting. So that was this test, right? So this was a group of younger people. You can check out the demographics for ages, but these were all, none of these were adults. So these were all children with autism or without autism or with anxiety. And they go through this test, and then you get to see this great big panel of data that I think is important to go through and see, like, what is it that we're looking at here? So if people are looking at this study, or looking at the article, and I'll kind of go through these panels, they're on page 37 of the article. And there are 1, 2, 3, 4, 5 panels there to look at. I thought I'd kind of go through those and just kind of explain what we're looking at here. So in panel A, what we're looking at is mean heart rate in beats per minute across these 3 groups. So each line represents a different group. And then you get 3 different phases, essentially, of exposure to certain events. So and each data point is a measurement point that they used to take all these measures. So they measured heart rate, they measured heart rate variability, and they measured salivary cortisol response. So you get these different kind of measures, and each one of these panels is showing a different measure. So what we see in this one, in the first panel, panel A, is that across these 3 different conditions, there were differences in both the resting state, measured by heart rate, and the response to the stress. But what we saw was that in the open squares, what we see are individuals with autism spectrum disorder without co-occurring anxiety. And they had a higher resting heart rate as a group than the other 2 groups. And then the middle group was people with autism spectrum disorder and co-occurring anxiety. And then the group with the lowest level of baseline average heart rate and beats per minute was healthy controls. The next, skip over that to the 3rd data point in this panel, and what you see is in this stress condition, everybody then, all of the individuals in this group responded by an increased heart rate. One of the interesting differences here is that the amount of change was lower for people with autism spectrum disorder and co-occurring anxiety relative to the change the other 2 groups saw, which is pretty interesting when we think about the correlation between experienced anxiety and physiological measurement. Right? That you would imagine that if you have anxiety, that your response to a psychosocial stressor would be greater, not less than. And interesting here, we saw that the responsiveness was actually a little bit less. So that's panel A. In panel B, what we're looking at is the cortisol response. So here we're looking at the activation or the activity of the HPA axis. And what we see is that they all started out pretty equal. And actually cortisol decreased for all 3 groups during this pre-baseline period. And then you introduce this psychosocial stressor, this stress test. And the 2 groups, other than the group with autism spectrum disorder and co-occurring anxiety, both had an increase in the cortisol. People with anxiety and autism had almost no response of the HPA axis as measured by cortisol levels, which is really interesting. Again, then we get this attenuated kind of response to a psychosocial stressor, even though we have an anxiety disorder that's present in this group. Panel C and D are great measures of the balance between the parasympathetic and sympathetic divisions of the autonomic nervous system. In panel C, we're looking at heart rate variability, which is a measure of parasympathetic or vagal tone. So what we see is across the 3 groups, you had heart rate variability almost the same across all 3. And then actually during this rest or this pre-baseline period, heart rate variability increased. And that means that as heart rate variability increases, heart rate tends to go down. And that's a measure of the activation or the activity of the parasympathetic nervous system. And then when we introduce this stressor, heart rate variability decreased for all 3 groups. So we see less parasympathetic activation. That's usually associated with an increase in heart rate. And then when that stressor is removed, or we get back into this recovery period, the variability returned back to its original levels. panel C is this high frequency, low frequency ratio. And that's a measure of sympathetic activity. But what we're looking at, and when we look at C and D together, is we're really looking at, one is parasympathetic activation, the other is sympathetic activation. We're looking at the balance between the two. Some really interesting stuff out of this panel, right? What we're seeing is that for individuals with autism, they had a response pattern that was during rest, they had very little sympathetic activation. Sympathetic activation increases during the stressor, and it returned back to its homeostatic state after the stressor is over. Same kind of pattern with people with autism and co-occurring anxiety disorder. And what we saw for healthy controls is that they didn't return so much to normal. Right? Their sympathetic activation stayed up for a longer period of time. Now, this last panel, I think, is really the money panel. And this is talking about this is the subjective experience of anxiety. Right? So here in this panel, they're measuring how anxious this group of people said that they were. And across these three groups, the real interesting part here is the amount of change, and that everybody said that they experienced anxiety. But what we saw here in this differential responsiveness in the physiological components of stress and anxiety is that people with autism and co-occurring anxiety disorders, even though they had less responsiveness of heart rate, they had less responsiveness of cortisol, and they had an attenuated response of the sympathetic nervous system, they still said that they experienced anxiety. So the subjective experience of anxiety was still present, but the physiological component was not as pronounced. That's really interesting when we think about how we can start to get organized by both the subjective experience of anxiety and the physiological correlates of it. And that they're actually separate phenomena that we could study differently, we can intervene with differently. So that took, for me, that point was the point at which in my kind of development of interventions where I came to the conclusion that even though we may not see physiological changes, we may see symptoms happen. And that led me down the road of looking at the change from baseline, or the movement out of homeostasis being a subjective, leading to the subjective experience of anxiety or uncertainty. And that as we looked at, we've talked about the intervention of looking at heart rate, and that when someone's heart rate changes from its baseline level, even if it goes down, that could still be anxiety. And we need to go and engage with that person then. That led to that, this study led to that intervention of looking at this physiological measure and responding to even a decrease in physiological arousal as if it were producing anxiety because it changed away from homeostasis. So that's kind of where this study led me to go to and all these different measures. And again, there's some pretty complex statistics in here that I think in terms of the larger point aren't as important to dig into, but some of these points about the physiological changes may be correlated with the subjective experience of anxiety. Sometimes they are not, and sometimes even a decreased responsiveness can still produce the subjective experience of anxiety that requires some intervention. So from there, Jerry, I'm wondering what some of the things that you've thought about as you read through this and kind of heard what I've introduced. As you think about it, I mean, there are lots of other phenomena we could talk about in terms of dissociation or window of tolerance, so many different kind of avenues to go into with that. Share some of your thoughts would be certainly interesting.
You know what came to my mind, both reading it and listening to you, was the work of a woman, I want to say her name is Lisa McTeague, and she does some work looking at anxiety, but using startle response. And in her work, people with social anxiety and people with phobias have a large reaction to a large startle response, as does people with single episode PTSD. But people with complex trauma actually have less of a startle response.
Yeah.
And what their research said is people with complex trauma have less of a reaction, but their reaction escalates over time. So, you know, when we begin to look at some of this physiology, and we begin to try to kind of hypothesize, I think in the article they came up with some hypotheses about why this might be true. You begin to think about this issue of both over-responding to situations, but also under-responding.
Yeah.
And, you know, if I'm with somebody whose biology, it tends to, when presented with something that we would think would be triggering, if I have an under response and then later on have an over response, I could be in a session with somebody talking about something, they seem like they're managing it really well, and then they leave and they blow up later on.
Right.
And we don't necessarily make connections between what we were talking about and what happened later on.
Right.
Or the person could have a major reaction with you and actually may be able to manage that and do really well, right? Based on your physiology. And so just looking at this issue of both trying to understand the physiology, but also trying to understand people's subjective experience and why that might be true, right? So trauma people always look at kind of fight flight kinds of reactions as opposed to withdrawal and submission.
Right.
Right, to kind of looking at that piece. So and I think it's a really interesting situation of looking at somebody with autistic spectrum disorder. What might be activating for them is just a change in the room. You know, it's like you just change the way things are. Their nervous systems are so sensitive in some respects. And so when we look at people with, say, chronic PTSD, they actually, it was like children who are exposed to abuse early in life or neglect, they actually have a blunting of their cortisol responses. Right. So you wonder whether in some ways people with anxiety and with autistic, the amount of activation of their nervous systems to so many events early in life actually downregulates their cortisol so that there's not it's almost dissociated from their stress response.
Right.
But it also takes less cortisol to get a larger reaction. So it doesn't necessarily, just because you have less cortisol, doesn't correlate with people's subjective experience of stress.
Right.
So I think it's a really interesting study, and when you kind of take that over to trauma diagnoses, you see similar types of discrepancies between physiological reactions and people's experience of stress.
Yeah, I thought that separation was really a fascinating component of this study.
Right. So what does that mean in terms of treatment or interactions, would you say?
I think that for me, I mean, this is what I kind of took away from it was, I mean, I tend to be, as a practitioner, really reliant upon information and data that I can base things on. And what this helped me to be able to do was to incorporate one more piece of information into a more integrated view of what might be happening, which helps me to remain curious longer. And it helped me to go, wow, I don't quite understand this one, or I don't understand how there is a discrepancy between these two pieces of information. Maybe I should keep asking questions about that.
Right.
Maybe remain curious and engaged about that. And for me, that was the implication. And I've found that for others as well. to stay engaged in the information gathering curiosity stage. And that was really helpful for me.
So let me ask you a different kind of question, because I think that's really interesting what you're saying. So you, as a trained clinician, you become more curious and engaged. But I'm wondering if somebody's not appearing to have a stress response, what do you think happens in their day-to-day interactions that is going to, in some ways, not validate their experiences, so be somewhat invalidated, right? That is because that is a small t, and I don't necessarily like the terminology small t. And the reason, let me kind of explain why. Because when you think about the way that SAMHSA defines trauma, they look at the event, they look at the experience, and they look at the effect, right? And so sometimes when we're talking about small t, people tend to think about just the event, because the experience is not a small t. It's actually their bodies are reacting as if it's a large t. They're kind of looking at that, right? And so I don't want people, in some ways, people listening to think just because it's a small t, the physiological experience of it is less than if, right? So I could, the example could be is I could be an autistic child and you move my room around. That's a small t. My physiological reaction may be larger than, say, a race car driver who has an accident, who's trained to be in race cars, right? And so I think the event is small relative to other event, but the impact isn't, and the experience isn't small.
Right.
That's how I think. That's why when we talk just about small t's, I think that it requires an explanation of, for the person experiencing a small t, their physiology doesn't differentiate between that and a large t. Right? That's a really important.
And to your point about kind of invalidating environments, I mean, I think we've all experienced the unfortunate experience of going to, say, feeling very, very sick and going to a doctor and getting blood tests done, and there's nothing wrong with you, but you still feel sick. Like that feels really invalidating. And it's almost like people can't help you unless there's something wrong. And if we're kind of looking at just the objective side and not also incorporating the subjective experience. And here's a great example of a change and a lack of change or an attenuated response to a stressor that resulted in a subjective experience, even though there was a very diminished physiological response to it. It gives kind of credence to that. I think is in maybe the introduction paragraph where the writers or the authors talked about anxiety as different than stress, and that anxiety has three components to it. One of it is cognition, the other is what we do, and the third is our physiology. And all of those components can be related to one another, and they can also be disjointed from one another, which is right down the pathway of trauma. That trauma does that. Trauma separates those three components so that they are not integrated with one another. And that's a symptom of exposure to adverse childhood experiences, or single event trauma as well, that breaking up of those three components of our subjective experience starts to get changed.
I also think that the article for me highlights, and that I've talked about this, is for an autistic syndrome population or a DD population, how sometimes we don't take a trauma-informed approach to it. And I think that understanding that the level of anxiety and sensitivity to the nervous system for both of these populations really enhance the risk for traumatic experiences. And so we tend to kind of look at the diagnosis and want to treat the behavioral components of that without really understanding the subjective experience of some of these types of things.
Right.
And I think this article and this discussion really highlights why we need to bring a trauma-informed approach to these populations on top of the behavioral interventions, as well as some of the other types of skill building interventions.
Well, and I think our episode that we had on autism really drove that home as a population I've worked a lot with as well. You know, such a vulnerability there. And I think, Jerry, your point, even though I'd love to argue small T trauma with you, the rest of the episode, I don't want to hijack it. But I really think, you know, the autistic vulnerability to trauma was so much of my focus while I was working with that population. And really, I think the other, you know, how do these two things interact with one another? I think this article raises a whole bunch of new questions on that too, which I think is really exciting. I almost want to fast forward 5 years with our technology and see, you know, what else we've learned going forward. But I think it's fascinating, this interaction and that subjective experience, and the cortisol piece. Again, just kind of explains a lot of the complexity that we see in fascinating ways.
Right. You know, the complexity of human beings is always challenging, right? Is that in order really to understand the particular individual in front of you, it would be great to go read a book on heart rate variability and stress response and to do it. And then you read some of these articles that say there's something very unique and different about the person that's sitting in front of you, or why you need to be open and curious about them particularly.
Mm-hmm.
You gotta look at some of these things to kind of manage that, because I could pull up a lot of articles that will talk about when you have a stress response, you have a high sympathetic reaction and you have your cortisols and you have your, right? That's your standard level. And then you have these adaptations for whatever reason, you know, for whether it's a dissociative process, a withdrawal process, whether their nervous system for some reason is constitutionally different, but their reaction to the environment is different based on who they are and what they've kind of had to deal with.
Mm-hmm. And really, in some ways, like, how can, you know, and I just think about, again, working with folks on the autism spectrum, it's like how much of some of this withdrawal and social anxiety and so many of these other things, what was kind of a genetic predisposition versus environmental. And I think that again, a lot of this throws in a lot of that complexity because of, you know, what's disassociation versus trauma, or not trauma, dissociation versus autistic behavior, and all this piece, and looking at, again, at this study, again, just shows that complexity is, you know, what's really going on under the skin, just adds a whole nother level of complexity, this whole thing, and what happened to you and what is happening to you. Again, we can kind of start to make those connections, but again, the complexity behind that is, it was nice when cortisol was just the stress hormone, you know, that it was just that easy. The more you had, the more stressed out you had, and yet again, the complexity of, as our technology improves and our thinking evolves, I think it's just fascinating.
Yeah, you know, too, something I think about is all the, because I mentioned earlier, this was the study that kind of led me to, we've got to be able to be engaged and responsive to internal states, even if there aren't physiological changes that we can measure. Maybe there aren't behavioral changes that we can see either, right? As Jerry said, somebody in session with you or somebody going through an experience may show outward signs of handling it just fine, and then you have a delayed response to it. Right? And like, how do we understand that? But as I thought about, like, this was the study that kind of helped me to use this data to design an intervention of, let's look at your internal state and let's do, you know, something as simple as wear a heart rate monitor so that we can take what's happening inside your skin outside, so all of us have access to it. and get organized by that information. But what I have found, and we're doing this, repeatedly with lots of different populations and age groups, and whether they're, people with intellectual disabilities, people with autism spectrum disorder, people without, who are traumatized, like going through all these different populations. I don't know that I've ever found a pattern that matched the study. But I have used it to design an intervention that was being organized by the internal state of that person. And that's what was important. Not that I found that, oh, they matched this group. And yeah, this is exactly what we expected. It's almost never what we expected. But we find something new about that person. And we go through the process of finding out, as you said, Matt, what happened to you and what's happening to you. Mm-hmm. We get organized around those kind of things. I found that something as simple as that really has helped a lot with developing interventions and having successful engagement between clinicians and clients and caregivers and children and family members and across all these different groups. It's really helped in leading to that kind of an intervention.
And Curt, I wonder, and Jerry, I'd love for you to jump in on this too, because I don't think I have a good necessary answer to this question. But if you're talking, let's say whether it's in a therapeutic environment or it's in a classroom, and you've got a diverse range of children with different levels of traumatic experiences, different kinds of mental states, maybe some kids that are doing really well, some that are really struggling. All this complexity is really fun to nerd out about, but if you wouldn't have access to like heart rate variability technology or getting cortisol levels, does this apply? Like, could I tell my wife, Sarah, about this and what it would mean for her to look at behavioral interventions in her classroom? I kind of struggled to find that in this. I thought it was fascinating and blew my mind, but at the same time, I was trying to look for, okay, what practicality for what most people's resources are.
The first thing that comes to my mind, which isn't the first thing I probably can't share, so I'll go to the second thing.
Well, that's good, Jerry. Way to self-regulate.
What comes to my mind is we oftentimes make we kind of assume we know what's going on with somebody based on their behavior, right? And so if somebody's overreacting to things, we're going to make some type of assessment of that and kind of, or if somebody's not reacting, we're going to be saying, oh, they're not motivated, or they're not moved, or they're not, right? We're in our minds, based on our experience of our own physiology and our reactions. Just as Curt said, his experience, he didn't see something like this, so he's not going to assume unless he reads an article or learns about that, right? So I think for teachers or for people individual, it's just because your client isn't reacting doesn't mean are they not being impacted by what you're saying? Mm-hmm. Right? Is that in a way that's a really important takeaway, is that somebody could look like they don't really care what you're talking about, but they're really being impacted by what you're saying. Or the other side is they could be really reacting to what you're saying, but it's not going anywhere with them, right? And so I think we have to really, knowing Sarah, she's already doing that, you really have to get to know your student. And really, as Curt said, is get more curious about when you see something going on, how do I try to understand that person's subjective experience of what's happening so that I cannot necessarily take my internal representation and think that that's reality, right? That's my reality. It may not be that student's reality. So I have to really check that out and kind of get curious about their experience. So I think that whether you're a teacher, whether you're a case manager, whether you're therapist, is in all these situations, or a parent even, is how do I stop and really, in some ways, check out with with the people I'm working with or interacting with or raising, what's happening inside of them and what their experience of that is.
Yeah. So in some ways, this more supports the trauma-informed approach.
Exactly.
Okay, great.
That's what I was trying to say about it. This is it's nice that it's done on a population. We don't tend to think about trauma in that population.
Yeah.
And yet, how much trauma is there each and every day for these individuals trying to manage these kind of reactions that may not look like trauma from their reaction to it?
Right, right. One of the key points I think of alluded to in the study is they talk about whether or not the physiological response to a stressor is adaptive or not. And we often think of this concept of adaptiveness being useful and good, right? But adaptive means reactive to. Right? And one of the things that we actually saw in this study is that the children with autism and co-occurring anxiety disorders did not have an adaptive response to the psychosocial stressor from a physiological standpoint. So their bodies did not react to organize them to deal with the stressor in the same way that children with autism without anxiety and the healthy or the typically developing children did, right? So there's an adaptive problem there, which may explain, as it gets into kind of some of the hypotheses for why this may be, that some of the symptoms we may see for individuals with autism with co-occurring anxiety disorders, that their bodies are not driving them to be responsive or prepared to deal with a psychosocial stressor. And so they may show a differential response to it that makes some sense to us now. And so and there you're going to Jerry's point of we infer intent all the time. And it's one of the things that I think our brains do it, right? Like they're anticipatory. So we infer intent and we get organized from an intervention standpoint based on our inferences of intent, right? As opposed to like more information about maybe this is part of the physiological response or a problem with the adaptiveness of a physiological reaction to it. Or maybe this is a part of the subjective experience that's getting in the way of things. So the more that we can use information to help guide our inferences of intent, right, may help us to generate much better information rather than it just be based on my own experience of what I have learned over the course of my lifetime. Right? And I'm inferring intent based on that rather than information that I may get from other sources and a wider variety of sources.
Mm-hmm. Very cool.
Right.
So any final thoughts on this? I think this has been a great discussion. And I know if you haven't read the article, hopefully we've sparked your interest enough to do so, because there is some really fascinating stuff. And it does help to see this in graph form as well, to have that in front of you.
Yeah, the picture is nice to have, isn't it?
The picture is very nice to have.
I understand it when I can look at the graphs and go, oh, that's the timing of how this changed. And
yeah.
So I think some important takeaways from this is that these systems are designed to both help us regulate and maintain homeostasis, but also to activate us to respond to our environment, right? Both sides of that equation. So when there's some demand in the environment, my body has to reallocate resources to be able to effectively respond, but it also has to recover from that response. Right? And so, in a way, we can have people who are over-responding and not able to regulate themselves. Or you can have people who are not responding and having difficulty organizing an adaptive response. Right? And I think that as trauma people sometimes, we tend to look at those people who are overreacting and overdoing it. But there are people who have been exposed to some type of experience, whether it be genetically driven or whether it be experiential, that they do not react to the environment and therefore have difficulty organizing what we would call an adaptive response.
Mm-hmm.
And it creates some problems for them.
Right.
So as we look at this kind of balancing neurobiology and physiology, is that we have to be able to activate when we need to and calm ourselves when we need to.
Right.
And when we don't have experiences, we can get disrupted in either end of those extremes.
Right.
Mm-hmm.
I find, Jerry, when you say like the ideas of that part of all of these responses are helping us to allocate resources, I think that's one of the gray areas of overlap between a trauma-informed approach and the behavioral tradition. Is when we think about what resources are at different levels. And so from one level of analysis, allocating resource is the balance between the divisions of our autonomic nervous system. That helps us to allocate resources in terms of our physiology. But one of the areas that we also allocate resources as living organisms is in our behavior or our reactions to what happens. That's another important allocation of a resource. And sometimes we get an over allocation of that resource, and other times we get an under allocation of that resource. It's just another level of analysis.
Mm-hmm.
And it's not that these two perspectives are antithetical to one another. They're just a different unit of analysis.
Sure.
So I think it's an important overlap between the two on why our two fields that we talk so much about the trauma-informed tradition and approach with this behavioral tradition, that they need to talk to one another, because we're talking about the same things in terms of allocation, misallocation, over allocation, under allocation. We're just talking about different units of analysis. So that for me is a great area of overlap between the two from a conceptual standpoint.
Sure. And as we learn more, we learn more. Some of the, even like our diagnostic manuals, right? The movement to a symptom-focused kind of categorization of disorders was a reaction to, say, psychoanalysis that made all these inferences about complex and edible complex, right? And we wanted to get away from that. So we went to one that really didn't talk about mechanisms and etiology at all.
Mm-hmm.
And now we're getting away from, say, psychoanalysis to neuroscience and biology and physiology that really does have some etiology and information. And now how do we, in some ways, go back and say, now we have to relook at our classifications in a different way because we have different information.
Yeah.
Right? And so I think your point of it is when we didn't have really behavior, we made up kind of narratives about what we thought was going on, right? Then we went to strictly behavior to kind of explain it or what things we could measure. And now what we can measure is so different.
Right.
It has to help us to redefine how we're seeing and understanding the disorders that we're looking at, because people who have anxiety disorders and depression may look more alike than people who both have depression, right? And that's the kind of things that I think some of this literature is beginning to raise for us, is some of our traditional ways of understanding have to kind of be re-examined and re-questioned as we move forward.
Let me ask you this question, because it came up as you were saying that, Jerry, because I totally agree with you. And then maybe I didn't because of what you were saying, not because you were, I say the exact same thing. So I'm disagreeing with myself maybe too, but so there, I'll confuse everybody. But I wonder, because I mean, if you think about something, I mean, this is for a lot of medical diseases. So like for example, something like HIV, we determine whether or not you have HIV or an AIDS diagnosis determined on lab results. Could what we're seeing in this article help? And even if we step outside our current list of mental illnesses and so it doesn't have to be defined as depression as we currently know it, but could we take some of these readings, and as our technology gets better, maybe on brain scans, I don't know, but is there something that we could take from this, and from a diagnostic perspective, look at these biomarkers and do a better job of creating psychiatric or behavioral interventions?
I think, Matt, the answer to that is yes. It will take us a long time. One is because it's really hard to change systems that we're using. And two is we have to learn a lot more about what we're doing and how to do it. So the answer is yes. But I think it also raises important questions that I think you raise a lot. And that is, how do you create a categorization of what's happening in the person when what's happening in the person is so much influenced by the environment that they're in?
Right.
So how do you begin to look at, which is a whole nother layer that creates a challenge, which is why this is a very complex issue to begin to look at it, because what we're learning about, say, trauma is really, this is an adaptation to environmental situations that allows them to survive in that kind of environment. So do we put a diagnosis on the individual, or do we put the diagnosis on the environment that they're in, right? So we've got a lot of work to do before we get to saying we got a really good diagnostic approach that takes things all into account, right? So it's the same way with, say, for example, ACEs. Lots of people are jumping on this ACE bandwagon and saying, let's just count the number of ACEs. But you can't really understand these ACEs without looking at the relational health or relational poverty that the person was growing up in. Mm-hmm. So, right, or the demands, or was there community violence? Was there lack of access to other things? Were there, right, or their financial? Was there marginalization of this culture kind of, right? There's so many factors that are going into whether an ACE is really going to have long-term impacts,
right,
on the doing. So I think you're raising a really important question, but it's also going to be a while before I think we have a shift in our paradigm that enough of us feel comfortable with, that we say, okay, here's where we're going with this classification.
Yeah. Well, and I wonder too, because I think one of the and I think it's sort of a reaction to a lack of resources, but I find it interesting is people really doing it, and some states have adapted this, as housing is healthcare. And so, and I think that addresses that environmental piece, is that if somebody doesn't have permanent housing, then until we address that, why, and you could medicate for certain diseases as well, but it's like, we know all health outcomes improve once you get in housing. So I think that there's some interesting, and I don't think it may be coming from our perspective where this justification is. It's just like, we're pissed off we don't have enough housing, and there's some funding to get people housed. But, I think that there's some interesting models out there that might be coming at it a little bit differently than we do, but have said, okay, without, addressing the environmental factors, we can't really address these other factors, because we know they'll still suffer as long as the major drivers there.
But then you put the diagnostic category on the environment versus the person.
Yeah.
And that's really what I'm raising the issue of, is our classification now looks at symptoms in the person, and then we diagnose the person.
Yeah.
And it's so much more complicated than that. And that's a perfect example. If you don't have housing and your kind of body's reacting, where is the disorder? In the person or in the environment? That's
well, and let me challenge you. Let me. I agree with you to a point, but I mean, are we almost using Curt's language, like environment? Yeah, but it's almost not inside the body. It's what comes out of the body because most of the DSM is on behavioral stuff. So it's kind of how what's inside the body manifests externally. So we're almost not inside the body. We're not looking at the environment, but we're looking at these, trying to measure some sort of behaviors, in, hey, have you had a nightmare, or this, that, or the other. So it's almost a manifestation.
right. And that was the best information we had when that diagnostic
Right.
system doing it. And all we're raising, I think everybody's raising, is we have access to new information. How do we incorporate that into however we're going to later on diagnose and categorize people?
Yeah.
Right? So it wasn't that there was something wrong with that system. It's just that we know different things now. So how do we adapt it and change it and kind of do it?
Right. I mean, there is always this temptation with paradigm shifts to kind of throw out the baby with the bathwater.
Mm-hmm.
That, you know, what was wrong, and what we want to go to is right, and that is not necessarily true. But what is maybe the best that we have right now, and maybe we just need to add to it, as opposed to completely get rid of it.
I think both things. One is you want to throw out the baby with the bathwater, but the baby tries to hold on to the bathwater and doesn't want to get rid of it, right? It's both sides of that are true, right? It's like, oh, I want to stay in this bathwater. No, we can give you new bathwater. Is that what taking away? We'll just give you some new
You
bathwater.
see where Jerry's head, he's like, I just don't want a mad baby.
Yeah.
Mad babies.
I just want the baby to keep sleeping. That's all.
That's right. That's right. Do not upset the baby.
Well, and I think it's exemplified too in the sort of the fight over trauma. I mean, in the latest DSM, as you looked at, there was a group advocating for a developmental approach to diagnosis, and I think all three of us probably would fall into probably supporting them in one way or the other in that regard. And yet, again, the baby held on pretty tight to that. So I think that was really frustrating. You see some organizations actually refuse to use the DSM because of that, and other things as well. But always, if you're going to change your paradigm, a rebellion or two is usually necessary in the process. So.
And is Matt's preferred response.
Yeah, absolutely.
I think people, there's probably, other than the American Medical Association, who has to publish these things and kind of looking at it, there's a agreement in the field that it's a very reliable categorization of that, but it's not necessarily valid any longer, right? And it's not that it wasn't, it's just that now with information. And so the problem is we don't really have something as of yet to replace it, right? We don't have a really good agreed upon. So we're agreed that this is not adequate any longer, but we don't have an agreement on what should replace it. And I think that's where a lot of discussion and negotiation and research and other kinds of things has to take place.
Great point. Well, I think that's a pretty good, I love where this conversation went. Great discussion. Curt, thanks for walking us through that. I know maybe you can preview a little bit the next article we're going to look at. Again, I'll put that up on the website a little bit ahead of time as well for everybody to read. So
we're going to move into a couple of interesting examples of how, when we look at physiological markers, especially heart rate variability, that we can predict some things like moment-to-moment fluctuations in affect or emotion, and that the title of one of the articles is Affective Instability in Daily Life is Predicted by Resting Heart Rate Variability. It's a pretty interesting study. And another one about how low vagal tone tends to magnify the association between when people are exposed to psychosocial stressors and the development of internalizing psychopathology. So a couple of pretty interesting topics to dig into, and there's enough to talk about that, that'll probably end up being a couple of episodes to get into both of those. But there's a theme between those two that we'll start jumping into next.
Very cool. So all the nerds are salivating already, including us. So Jerry, Curt, thanks so much. I apologize. I was absent for most of the first part. I might have to run to Costco to buy a new computer. So why not? I'm sure it's on sale. So, but I thank everybody for joining us again. Curt, thanks for organizing this. As always, you can find the article we discussed today, as well as if you want to read ahead and look at next week's as well, that'll be at our website at traumainformedlens.org. Thanks for joining us, and have a great week.